So if you have a complication, have no disclosure. The frequency of these adverse events that we just heard about varies. A recent report from the UK was a little bit higher than what just presented at this podium. And the presentation can be early or delayed, which we see a lot in our tertiary care center. And here are some of these complications. And very basically, one of the problems is that as time goes on, this rate goes up. We've reported a technique for removal suburethrally, and we've reported also our data both for single outcomes like pain outcomes, urinary incontinence. The big problem is how do you report when you have multiple domains to report to really take into account the whole patient. In the Journal of Urology last year, we reported one of these techniques, which uses a perfect outcome or the UDI-6 short form. So the question there, with these kind of tools, do these symptoms improve globally after suburethral sling release, and are these improvements durable? So the design of the study is a bit complicated in a very short time, but we had about 433 women, and they're all referred to us. I don't do midurethral sling, never did, never will. And so they're all referred to me. This group only analyzed those who had one midurethral sling removed, not many. And we excluded everybody else who had neurogenic bladders, mesh repair, etc. We had about 230 patients that complete data symptoms, some with UDI-6 complete, and very unfortunately not a lot with sexual function, but many of those people are not sexually active beforehand, so we don't have any good baseline. The ideal outcome is obviously ideal, patients being continent, pain-free, sexually active afterwards. Obviously, they were incontinent to start with, presumably to get a sling. If you look at the type of slings in this series, we have retropubic and transobturators. If you look at the follow-up, it's about 23 months after removal of the slings. If you look at the symptom domain, that's probably the most important thing for you to realize, is that basically you're not dealing with one symptom, two symptoms, but 3 or 4 or 5 symptoms per patient, which complicates the analysis of their outcomes. There was no difference in sling type, by the way, so they all can cause the same trouble. If you look at the results after sling removal, you can see there's different way to categorize between their presenting symptoms, dysuria, pelvic pain, UTIs, incontinence. And if you look at basically an ideal outcome, someone perfect, obviously that's going to be low at 10%. If you if you exclude sexual activity, that goes higher. If you look at adding a minimally invasive anti-incontinence procedure like Botox or bulking agent, then the numbers go higher. If you look at the symptom score, if you look at the UDI-6, which covers basically urgency, stress, voiding issues, and pain, all those values are very significantly drop afterwards and definitely meet the 50% cutoff of their values. Baseline is 50. If you go by 25, which is half, you get about the same result with the UDI-6 score than with the ideal incontinence score that we describe. It is a referral population. The questions on sexual activity are limited. But basically, we found with this type of analysis that the improvements in multiple simple domains remain stable over time, and that you can use this ideal score, the UDI-6 scores, to analyze those complex patients. Thank you.
Any questions? From what I understand then, 47% of the patients were lost for long follow-up. Could you comment on that a bit? Who were they?
Yes, there was loss of follow-up, and there were, we're a tertiary care institution, so obviously people go back to where they came. And that's one of the problem of long-term data, which I presented in my first paper as well. There's nothing we can do about that. We've tried to contact them. We have a long-term paper on that with questionnaires only. But complication like exposures we will not get if people don't come back. That's a big problem. We can only present data on people we see back. So we've published that in another paper where basically those that live within 60 miles radius from our facility are the ones most likely to come back. And I think it attests to the fact that they're not doing too badly, so they don't feel like they have to come back necessarily. Now, over time, since I've been same place for 25 years, I do see people coming back years after where the leakage has worsened or the pain has continued or the urgency is no better. So I urge you all to follow your patients, whether they had a sling and you don't know what happened to them, or whether you had removed the sling and they still have problem afterwards.
Thank you. Thank you.